These are the valgus and varus stress tests to test this stability of the ligaments. So for the UCL, I'm going to provide a valgus stress test. The best position is to flex the elbow around 20 degrees and then providing that valgus stress to test the UCL, and then a varus stress to test the LCL. So a positive for either of these would be laxity compared to the other side.
Nice.
This is the milking maneuver special test to test the stability of the UCL. So I'll have the patient in 90 degrees of elbow flexion and supination. And then grabbing a hold of her thumb, I'm going to provide a valgus stress. And a positive for this would be excessive motion. This is the moving valgus stress test to test the stability of the UCL. So I will bring my patient into 90 degrees of abduction and elbow flexion. Then I'm going to provide a valgus stress as I extend the elbow. And then if I get a reproduction of the patient's pain between 120 and 70 degrees of flexion, then this is a positive test. These three tests are to test for lateral epicondylitis. So first is Cozen's test. So I'll have the patient extend her elbow, and then I'm going to have her extend her wrist. And then I'm going to provide resistance. If this elicits pain at the lateral epicondyle, then this is a positive. Then I can go into the Mills test. So I'm going to extend the elbow, flex the wrist, and then flex the fingers. Again, trying to stretch those extensors. If that brings on the pain at the lateral epicondyle, then this is a positive test. And then the last one's called Maudsley. So having the patient stick her hand out, I'm going to provide resistance distal to the PIP. And if this reproduces the pain, again, in the lateral epicondyle, this is a positive test. For the Maudsley's test, you are providing a resistance proximal to the PIP, not distal. This is the biceps squeeze test to test for potential biceps rupture. So I'm going to have the patient bend her elbow at around 60 to 80 degrees of flexion. And then I'm going to squeeze onto the bicep. When I squeeze, I should see a little bit of supination. If the biceps does have a rupture, then there would be no supination happening. This is the elbow flexion test to test for cubital tunnel syndrome. So I'm going to have the patient go in a position like so and bring her wrist as far back as she can. Then I'll have her hold this for about 3 minutes to see if she gets any of the reproduction of her numbness or tingling. To further sensitize this, you can have the patient abduct and then also look for those symptoms. Another test for neurodysfunction of the cubital tunnel is Tinel's. So I'll have my patient rest her arm like so, and then I'm going to tap into the cubital tunnel. And if the patient gets reproduction of her complaints that she's complaining about, then this is a positive test. This is the pinch grip test to test for involvement of the AIN nerve. So I'm going to have the patient try to touch the pointer and thumb tips like so. If the patient cannot do this or goes into more of a teardrop, this is a positive sign. This is the Watson's test to test scaphoid instability. So starting the patient in elbow flexion, I'm going to ulnar deviate and extend. Then I'm going to palpate for the scaphoid. Then I'm going to radial deviate and flex. And I'm also looking for a thunk or clunk of the scaphoid, and that would indicate a positive test and instability. These are shear tests for carpal instability. So starting with the scapholunate shear test, I am going to start with finding the scaphoid. So I'm going to have her lift up her thumb so I can find the snuff box and then go to the base of that and then find the scaphoid. To find the lunate, I'm going to go to the third metacarpal, down until I drop off, then more towards the ulnar side and more proximal to find the lunate. Then I'm going to shear the two. Then a positive would be any hypermobility or the patient's complaint of pain. for the luno triquetrum, I am going to put my thumb on the lunae and then find the pisiform, and then drop down and find the triquetrum. Then I'm going to shear that as well. And also a positive for that would be instability, excessive motion, or their complaints of pain. This is the Lichtman test to test for midcarpal instability, usually between the proximal and distal row. So I'm going to find that, start in radial deviation, then I'm going to find that the area, then I'm going to axially load and provide an ulnar deviation, and I'm feeling for a jump of those carpals, and that would be positive and indicate instability. This is the Shuck test to test for carpal instability. So I'm going to have the patient sit like so with her wrist in slight flexion hanging off the table. Then I'm going to provide flexion also at the MC joints and then have her resist this motion. If this brings on her pain, this is a positive test. This is the CMC grind test to do if a patient is complaining of pain in this area. So first I'm going to stabilize at the radius, then I'm going to axially load the first metacarpal, then I'm going to circumduct while providing that load and looking for her complaints of pain or any crepitus. This is the piano key test to test for just joint integrity at the distal radial ulnar joint. So providing a downward force on the distal ulna, and I'm looking for any reproduction of her complaints of pain as I do that shear. I can also do a distal radial ulnar joint shear test where I can stabilize the radius and then provide a shear of the ulnar back and forth, anterior posterior. Again, any complaints of pain right at the joint would be positive. This is the UCL stress test for the thumb to test for ligamentous stability of the UCL of the thumb. I'm going to stabilize in about 30 degrees of flexion, then provide a valgus stress, looking for her complaints of pain or excessive motion. If there is motion greater than 30 degrees, then this is also a positive. Meniscal. This is the ulno-meniscal triquetral dorsal glide test to test for TFCC involvement. So with my patient's arms like so, I'm going to palpate the pisiform, and then I'm also going to palpate the distal ulnar joint, and then I'm going to compress to create a shear. If she gets her complaints of pain in that ulnar side, then this is a positive test. This is the press test to test for TFCC involvement if the patient comes in with ulnar-sided pain. So I'm going to have the patient sit in a chair with arms, and then using her arms to push herself up. She can use her legs a little, and while doing this, if she has the reproduction of her pain, this is a positive test. This is the supination lift test to test for TFCC involvement. So you can have the patient relax their arms on top of the table in full supination. This patient unfortunately cannot supinate that arm, so another way to implement this test is to grab underneath the table and push up. If she has complaints of her ulnar-sided pain, this is a positive. If you want to do the test with the hands on the table, you would just provide resistance here, having the patient lift up. This is the ulnar impaction test and the load test to test for TFCC involvement. So I'm going to have the patient lift her arm up like this. I'm going to ulnar deviate her and then axially load. And then I'm loading that fourth and fifth, the digits. And then for the TFCC load, I would then go back and forth between flexion and extension while keeping that ulnar deviation and the load. And a positive for this would be any of her reproduction of pain for both of these tests. This is the Bonnell-Littler test to test for joint motion. So say she's limited at the PIP in the first digit. So first I'm going to keep the MCP around neutral and assess the PIP motion. If it's limited, I don't know if this is due to the joint itself or the intrinsic muscles. So to test that, I'm gonna flex the MCP and then again assess the PIP motion. If I get an increased motion after flexing the MCP, then the limitation was due to an intrinsic muscle. If the MCP is flexed and the PIP is still limited in motion, this is a joint problem. This is the Haynes-Zancoli test to test for limitation to determine whether it's joint or the oblique retinaculum that's tight. So if she's having limited motion in the DIP, I can assess that motion here passively, and then I can put the PIP into some flexion and then again assess the DIP. If there's no change in motion with the flexed PIP, this is indicative of a joint issue, and if there is more motion when the PIP is in flexion, then this is a ligament issue. This is the Finkelstein's test to test for possible de Quervain's issues and pathologies. So first I'm going to have the patient grab her thumb like so on the affected side, and then I'm going to maximally ulnar deviate. If this reproduces the patient's pain right where the snuff box is in that area, this is a positive test. This is two tests to test for the activation of FDS and FDP. So for FDS, I'm going to constrict all other fingers except one, have her flex that up, and then to see if the DIP is relaxed, I'm going to go back and forth like so. If her finger is, if the tip of her finger is moving, then this shows that the FDS is intact. To assess FDP, I'm going to have the fingers in extension, block all other motions except the DIP, and then tell her to flex her fingers down. If the patient can do this, then this shows that the FDS is intact. I mean the FDP is intact for the DIP. This test can test the integrity of the extensor hood if the patient has problems extending their fingers. So having the patient off of a table like so, where her PIPs are flexed, I'm just going to provide resistance against her fingers here and tell her to lift up. If she is unable to go against my resistance, this is a positive finding. This is the Phelan's test and reverse Phelan's test to test for possible carpal tunnel syndrome. So for the Phelan's, I'm going to have the patient put the back of her hands together like so, and then I'm going to have her stay like this for about 30 or 60 seconds, and I'm looking for the reproduction of the numbness and tingling in the front side of her hand where the carpal tunnel is. If I want to do a reverse Phelan test, I'm going to have her do the opposite, so hands together and then drop down into more wrist extension. Again, holding for 60 seconds and looking for those reproductions of her symptoms. This is the hand elevation test to test for carpal tunnel syndrome. So I'm going to have the patient raise her arms all the way up ahead of her. Yep, just like that. And then face her hands this way, so flexing them all the way down. Holding this position for 3 minutes to find reproduction of her carpal tunnel syndrome in the median nerve distribution. This is the carpal compression test to test for possible median nerve involvement in carpal tunnel syndrome. So I'm going to use a dummy thumb and compress the median nerve. And I will hold this for about 30 seconds, and I'm looking for a positive for any reproduction of her numbness and tingling or pain. This is the Tinel sign at the wrist to test for median nerve involvement. So I'm going to tap on the median nerve, and I'm looking for any of her complaints of numbness and tingling distal to that area. This is the Tinel sign at the wrist. So I'm going to tap along the median nerve. And a positive for this would be any numbness or tingling that she has distal to this area. This is the Frohman sign to test for ulnar nerve involvement. So I'm gonna have this piece of paper and stick it into the web space, having her clamp down with her thumb. And I'm gonna try to pull it out. if I see the patient start to compensate by hyperextending the MCP and flexing the PIP, then this is a sign of compensation because the adductor pollicis is not working properly because the ulnar nerve is not intact. This is the Allen-Teste test for vascular involvement. So first I'm going to occlude the median and ulnar arteries, and I'll have my patient go from opening and closing her hand 5 times. And then relax. And I'm going to let go of the ulnar artery and then look for that filling. Then I'm going to occlude again and have her repeat the 5 times. And then relax, and then I'll let go of the median artery and then also look for that filling. If there was no filling occurring, this is a positive test.